is.
This particular evening, we were dispatched for a juvenile patient that the family believed to be having a seizure, but they weren't 100% certain. Upon our arrival, the patient appeared to be unconscious, unresponsive, but breathing. It was deemed that they were in the postictal state from an apparent seizure. However, the family stated that the patient did not have a history of seizures. The father stated she had recently battled a sinus infection that she was still currently being treated for, as well as a heart condition that she doctored in Pittsburgh for. It was known that the patient became hypoxic after having a seizure. Therefore, we decided that this patient would be best to be loaded into the ambulance and placed on oxygen for further treatment and a transport decision as to where to go.
All right, we got her on oxygen. Let's go ahead and get her on the monitor real quick, get some vital signs. If you gave me the blood pressure cuff, I'll go ahead and throw that on her real quick.
Your main focus in the status epilepticus patient, as well as most seizure patients, is going to be, first off, making sure they do not injure themselves in any way. After that, you want to start with your basic ABCs, making sure their airway is open, they remain breathing, and they obviously keep a pulse. Once you get to that point, you obtain your baseline set of vitals. If they are deemed to be hypoxic, you want to place them on high-flow oxygen, typically by a non-rebreather at 15 liters. If they continue to seize, you definitely want to get the seizure stopped. In doing so, your initial treatment can be benzodiazepines, administer Versed. Typically here where I'm from, we give 2 milligrams to start off with and see how that goes with the patient. Once in the hospital, they can be put on epileptic medications like phenobarbital or Keppra.
Pulse ox is coming up to 100% now on the 15 liters. Heart rate's coming down a little bit, so as long as she doesn't seize anymore, we'll be okay. They said she didn't regain any consciousness, so I'm going with status epilepticus since she didn't regain consciousness or anything like that.
Good.
Alright, so she's seizing again, so let's get her on that monitor real quick. We need to maintain airway, keep it open. I'm going to go ahead and start an IV and give her 2 milligrams of Versed to get the seizure stopped.
At this point, you really need to be thinking about a transport decision. Can your local hospital where you're based out of handle a status epilepticus patient? If not, you would definitely want to consider air flight to the closest appropriate facility. In the rural area that I live in, our decision that night was to check for availability of aviation and attempt to fly this patient to the closest appropriate facility. On this night, we were able to initially obtain an aircraft for flight. However, due to the rural area we live in and the distance that we were away from the helicopter, it was more appropriate to transport her to the local hospital to be stabilized and then transferred from there. As you can see here, there are different types of triggers for status epilepticus. You have epilepsy syndromes, cerebral damage, brain tumors, electrolyte abnormalities, drug alcohol overdose or withdrawal, as well as encephalitis. So with your epilepsy syndromes, some people are born with this, that they just have a general history of epilepsy, which is also known as seizures as we know it. So growing throughout their years, they will have random seizures, but they will also be treated for this usually by their doctors and be on an epileptic medication. So cerebral damage is going to be your basic trauma and traumatic events that could happen to your brain, which could also include TBI. This could range from a wide variety of events to include a motorcycle accident with severe head trauma, as well as even a severe fall. Something else that could begin to cause brain damage would be your strokes. whether it be a hemorrhagic stroke or an ischemic stroke, which could cause encephalopathy, which is a lack of oxygen or decreased blood flow to the brain. Brain tumors fall next in line to not just include your cancerous tumors, but it could also be a simple mass that is created by something as simple as a sinus infection that most people probably would not be aware of. Something else along the effects of a sinus infection would be someone that has had the flu that begins vomiting and is vomiting for several days. That could lead to an electrolyte abnormality between sodium all the way to calcium, potassium, and so forth. That could cause that shift in the brain and cause them to start going into seizures. And the longer it takes to get those electrolytes back on board with the patient, the longer it's going to cause them to be into status epilepticus. Drug and alcohol overdose, I believe, is going to fall into a patient-by-patient realm and all in how their body reacts to whichever drug it is that they are ingesting or how much alcohol they have ingested. Two other syndromes that I would like to make mention of is Rasmussen's syndrome, which is a chronic neurologic disorder known as inflammation of one side of the brain causing seizures that could be difficult to stop. This most commonly occurs in children between 2 and 12 years of age. You also have Lennox-Gastaut syndrome, which is an epilepsy syndrome usually beginning during childhood. A hallmark sign is several types of seizures that occur frequently, even as much as several times a day. This is usually disorders of brain development and fetal development damage of the brain.
When we made initial patient contact, the patient was having what we call a grand mal type seizure with the full-on shaking of her extremities. As we spoke with the patient's father, he said that he had initially arrived with her, found her unconscious, and she was having approximately 3 seizures that she did not regain consciousness within about 15 to 20 minutes, and that's when they dialed 911. He said that she had a history of a heart condition that she doctors for in Pittsburgh, as well as recently being treated for a sinus infection. When we initially arrived, she was unconscious. She did begin seizing for us. We were able to get a quick pulse ox, which showed 78%, due to the active seizure, which is causing her to be hypoxic. At that point in time, we decided that she was going to be a load-and-go patient, and her best course of action in treatment was to get her in the ambulance and get her transported either to the hospital or an LZ to fly her out to the closest facility. Upon placing the patient into the ambulance, we placed her on high-flow oxygen at 15 liters via non-rebreather, as well as opened and maintained her airway. We then placed her on a cardiac monitor in which she showed to be in sinus tachycardia and obtained a baseline set of vitals to show hypertension and a normal glucose. The glucose is imperative to obtain as it can mimic the postictal state of a patient or be the actual cause of them being in a seizure. We also started an IV and administered 2 milligrams of midazolam to attempt to sedate the patient, and which was successful to get the seizure to stop.
Upon arrival at the ER, the patient was taken to the CT scanner to have a CAT scan completed. Upon getting the results back, the ER doctor noticed that the patient had an abscess on her brain. At this point, he wasn't sure if it was cancer or if it was just simply because of the sinus infection. At this point, he decided to have the patient transferred to a more appropriate facility to do a more in-depth assessment of this patient to determine exactly what was going on with them.
After the patient arrived at the higher level of care facility, more tests were ran, and it was determined that the patient had an abscess on her brain that was due to the recent sinus infection that she had been doctoring for. They were able to get the seizures to completely stop, as well as started her on high-dose antibiotics. After she received those at the facility and being admitted, she was discharged with a PICC line and returned to home to receive more antibiotics. The patient has since made a full recovery and is back to her normal everyday activities. This just goes to show the importance of knowing the different causes of seizures, as sometimes it could be a drug overdose, it could be a traumatic event, or it could be as simple as they are an epileptic patient or a sinus infection. But your treatment for these different things will always start with getting the seizure to stop, but then you need to determine how to fix it totally, as to whether they need to be on seizure medication permanently or it just needs to be strong antibiotics for the time being. If they continue to go into a seizure, it could lead to brain injury that is permanent, or it could ultimately lead to death due to them becoming hypoxic. The key takeaways from today's video and case study is to always start out with your ABCs. You never want to jump those. Make sure the airway's open, they're breathing, and they have a good pulse and circulation. Once you do that, determine exactly what's going on. In this case, the patient was in status epilepticus, which is a seizure lasting longer than 5 minutes or 3 or more seizures back to back without regaining consciousness. Once you determine that, next is your vital signs, maintaining the airway again, and placing them on oxygen to reverse and prevent any further hypoxia. Once you do that, you want to get the seizure to stop and get them transported to the closest appropriate facility.